In a world increasingly shaped by technology, the HumanUp Imperative explores the significance of human connection with each other, with the communities we serve, and perhaps most importantly, with ourselves. Join Rex Wallace and his guests as they discuss the ever-important role of authentic, meaningful connection in healthcare. It's time to Human Up.
Hey everyone, welcome back to the HumanUp Imperative. Hey, today we have a special guest who I met about 3 years ago, I think. We were facilitating a virtual client conference, so our book of business had grown. We really wanted to pull everyone together for this virtual conference, and you know, our clients hear us speak a lot, so we like to recruit really compelling, really knowledgeable experts to come in and speak to our clients, right? It helps keep us grounded too, because we like to surround ourselves and our clients with other smart people, not just our team. So was looking for a customer experience expert, and this guy was recommended, and we brought him in for the presentation, and it kind of blew my mind, right? And I think everyone on our team and many of our clients, it was one of those presentations that sticks with you. And he's such an interesting guy already, but when he starts talking about this stuff, about customer experience, it's so thoughtful and it's so thought-provoking. And when you marry those two things together, it makes for a very good conversation and a very memorable conversation and presentation. It's not a presentation today, it's a conversation. But and he spends most of his time in pharma, in life sciences, as opposed to where I spend most of my time in the payer industry. So we unfortunately don't overlap enough. So I don't get enough time to work with this guy. So I'm really excited to be able to bring him on today, introduce him to you if you don't know him, and just have this conversation around customer experience and pharma and payers. And I think what he calls pea soup we're going to get into. So yeah, please join me as we human up with Rich Schwartz. Rich, so good to have you, man.
Hey, Rex, great to be here, and thank you for that very kind introduction. I still remember that day fondly. That was a fun session.
It was so fun. And yeah, our team, the ones that were there back then, we've grown a lot since then, but yeah, we talk about it every now and then. In fact, we were at a conference just this week and saw someone that kind of resembled you, and we were is that Rich?
Poor guy.
It was not you. And yeah, but let's start with your story. For the people that don't know you, who is Rich Schwartz? What's your story?
So, like you said, I work in customer experience, and I primarily focus on life sciences. So pharma, biotech, medical device, diagnostics, and I've worked in and around that industry for about 30 years. I fell into it kind of accidentally. I was living in southern Appalachia. I was a filmmaker, so making films about health and people's attitudes toward health in one of the poorest regions in the country, kind of your quintessential health desert, or health mountain, if you will. And I ended up doing a project for a pharma company around launches, and then they brought me in to do work around communications and to focus as a storyteller. And I didn't even really understand what a pharmaceutical company did exceedingly well then, and I fell in love with the problems. So
there are a couple.
Just a few, and I spent about 10 years at WebMD. Focused on reimagining how we communicate with doctors and patients.
I did not know that about you. And I've seen some amazing photo shoots from Appalachia. Is that how you say
Appalachia?
It? Appalachia.
Yeah.
Appalachia. Right. So, and the challenges there. And I grew up in northern Arkansas, so I can. Not anywhere near the same challenges, but plenty of challenges and some, kind of similar. So yeah. So you weren't born a storyteller, but it sounds like you became one pretty quickly.
Yeah.
So you talk about trust as a clinical variable in healthcare. What do you mean by that?
See, well, if if you stand still long enough, I will talk about something I call experience as a medicine, which
Right.
look, when you enter into any experience, you enter into it with expectations, and your expectations plus or minus your realities, that's generally the experience that you have. In healthcare, gosh, nobody taught us how to go through any of this. Nobody taught us how to be a patient. And so we enter into healthcare and we're normally at our worst. We're sick. We're scared. We're not sure what's about to happen to us. And we're hoping that the people that surround us are people that we can trust, right? Trust and reciprocity, I believe, have clinical implications, and I talk about it as experience as a medicine. If you look at the work by Mazzarelli and Tresiak in Compassionomics, you look at Kelly Harding's book, Rabbit Effect, anything by Dr. Elliot Crum at Stanford on the treatment effect, what it tells us is that when we feel good, when we feel safe, when we're inside of a bubble of reciprocity, we simply do better. It is an unfair advantage against disease, in my book.
I just finished Compassionomics recently, and it's got, I don't know, hundreds of examples, right, of and not just, I guess when I first read it, I thought it would be mainly from the healthcare delivery side. It's largely from that side, like clinicians who are touching patients, but there's a whole at least one whole chapter on quality within health plans, right? Which really resonated with me, obviously, because that's what we do. But it talked so much about, people's clinical outcomes improve if the doctor touches their shoulder, if they're more likely to adhere to their medications, if they know they're doing it because somebody cares whether or not they took that medicine, even if it's the care manager at the health plan, right? But I mean, hopefully it's some family too, but it's not always. So there's so much to learn from that book, I know, and the other ones that you referenced.
The whole notion that sparked the title for Rabbit Effect was they were doing research studies on rabbits, and there was a cohort of rabbits that should not have been doing well in this research study, and they couldn't figure out why they were doing well. And what they noticed was the graduate student that was their caretaker was picking them up and holding them. So just that human touch sometimes. And look, when you walk into a doctor's office and they hand you a prescription as they're walking out and say, the nurse will have a prescription for you at the front desk, versus, hey, I really think this is going to work for you. I've seen it work with other patients. I have great confidence in it. We're in this together. Let's try it. Let's see how it works. You're simply going to do better.
Yeah.
Period. It's just how we're wired as a species. And we don't pay enough attention to that experience as a medicine. And that's part of the work that I do with pharma companies. Look, they create incredible products, but sometimes the way those products are packaged and pushed out to us isn't so incredible. And I'm trying to help them fix that.
Mm-hmm. You said something a minute ago, and before we go too far down some other side, I want to ask you one thing. So you mentioned we don't we're not taught how to become patients, right? And we put so much work into educating providers and clinical staff and even our health plan staff on their part in this experience. And we try to equip members and patients with checklists and, hey, don't forget to talk to your doctor about this. But I don't know, I can't think of an example where we've really intentionally went to educate our health plan members on how to not even a good patient, because that could come off wrong, but an effective patient, to own the experience, from your standpoint too. And that doesn't mean they're going to trust the clinician anymore. Like, that's all on the clinician, right? But if you're making me think there's more we can do on the patient and member side to improve improve their experience from their end. But yeah, thoughts on that? Have you done anything on educating patients?
I have, and look, there was a pivot period for me. I've worked in and around pharma for 30 plus years, and I thought I was a hotshot. I probably had gotten to a point where I had quite a bit of arrogance around. I know what this is. I know what patients are thinking. I know how to tell patients what to do. And then suddenly you find yourself as a patient, and I got sick, and not a little sick, like a lot sick. And sitting there in my doctor's office, the thought that hit me was, I just got a full-time job that I'm probably going to have forever, that I don't want. It pays in reverse, and I'm completely unqualified and totally unprepared. I mean, educated person, works in the industry, and just had no idea what to do. Mm-hmm. That's a scary feeling.
Yeah. Yeah, education is I feel like it weaves itself into every engagement that we have with clients and, working with payers, and whether it's educating them or helping them educate, providers or patients or vendors or whatever it might be, just ensuring people are on the same page and can we teach self-awareness? How do we teach that?
Gosh, I'm struggling with that every day.
So talk about this. I love the way you describe it as pea soup, and I know, it sort of describes the environment you find yourself in and the entities that you're working with. But what is pea soup?
Well, look, when you find yourself as a patient, you have a physician. You're working with a system, a provider. There's probably a payer involved, and maybe you're not on private insurance. Maybe you're on public insurance, so there's public sector involved. Then you have a pharmacy, and then you have a PBM, and you look at all of these entities, right? Medicare, Medicaid, public sector, VA, public sector. They all start with P, but you've got a patient who's swimming through this pea soup. And if you look at the incentives of these various industries, the pharma company, the providers, the patients, the physicians, everybody involved, they're breaking each other's shit all the time. Sometimes inadvertently, right? Like, you get a prescription from your physician and you go to the pharmacy, and meanwhile, the payer has changed what that prescription is at the counter. Or the pharma company may have pushed a bunch of information out to a patient who walks into a doctor and starts having a conversation about something that isn't even relevant to that patient because they saw an ad on TV. Or you get a prescription and the doctor knows it's going to work for you, and you end up with prior authorization and your prescription's delayed for days and months. Well, it's hurting the patient, that's hurting the revenue of the manufacturer, and nobody's really winning in that equation if this person ultimately is going to get the medication one way or another.
And when they do get the medication, or when they go to the pharmacy, so the patient goes to the pharmacy, and pays the copay. Let's say it's $100. Yeah, I mean, how is that $100 divvied up in pea soup?
How much time do we have? So anybody that hears me go through this, somebody jumping in the middle is going to assume that I hate this industry. I want to be perfectly clear. I love this industry. It's given me my life, quite literally. It's given me, a nice life that I had. It's given me my wife. I met my wife in a pharmaceutical company.
Oh, wow.
I love this industry. I think they're miracle factories. I can't imagine a cooler job than making products that change the course of disease and damage and injury and illness in the human body. But I also think we've lost the script, and it's not just pharma. So if you took, let's say you're a patient and you spent $100 at the pharmacy. Well, the manufacturer has set what's called a WAC, and it's a really poetic name. It stands for average wholesale cost. It's not because it's out of whack, but you'll hear in a moment that it is, because it's not really a stable number. Say they've established a WAC, and that WAC is $60, right? So you're paying $100. Theoretically, they're getting $60. Then there's this group called a PBM. And a PBM is a pharmacy benefits manager. CVS owns Caremark. Caremark's one of the big PBMs. There's Optum, there's Cigna. Well, they are negotiating the price with the manufacturer on behalf of the insurer and the employer. They get a piece. And we're going to jump off of that for a moment, and we're going to go to a thing called 340B. 340B was put into place in I think the 90s, might have been sooner. And what it was, it requires manufacturers to give hospitals who serve people in poor areas an additional discount, a much bigger discount. But the problem that's happened now is the hospitals keep the spread, and it's not a small amount of money. Pharmacy gets a fee, the insurer actually overpays relative to the acquisition cost, and the patient in this low-income area that it was meant to help, guess what? Probably paying full price. So we'll go out of 340B, we'll go back to just your traditional insurer. So you're employed, you have an insurer. Well, your insurer, of that $100, probably gets a piece too. They actually receive the majority of the rebates that the PBM negotiates with the pharma company. Those rebates don't always and quite often go to the patient. So then there's the pharmacy. They're reimbursed by the PBM. They're operating on a very, very slim margin. They might get $8. So we got $60. We've got maybe $10 to the PBM. None of this is going to add up, by the way, so don't take a pen out. The insurer might get 10 or $20. The pharmacy might get $3. They might get 10. Then there's a wholesaler. There's a distributor. These are really big companies, operate on razor thin margins. They get a piece. They get $2 to $3. And the patient, based on that $100 list price, usually no rebate, no benefit, unless the plan happens to pass it through. Okay? And here's where I probably need to check my Ring camera and make sure that they're not outside my door. If we go back to that 340B, in 2024, and this one will make you choke a little bit, 340B drug purchases exceeded $110 billion in gross sales. It was about 15% of the total U.S. drug market. There are over 50,000 contract pharmacy arrangements, many with major chains, not community clinics. Some health systems generated hundreds of millions of dollars annually in 340B margins. And I'm not making any accusations, but that needs some clarity. And it needs some clarity because it's not clear how they reinvested that back in patient care. It's not clear at all. And it needs some clarity because taxpayer dollars, for one, it's impacting revenues of manufacturers. And 66% of bankruptcies in the U.S. are health related. 66%. North of the wall in Canada, it's 15%. So, that's a lot. I threw a lot of numbers and a lot of percentages out at you, but that's a great example of swimming through pea soup.
Yeah, and I mean, the incentives are clearly misaligned, right? And this isn't the only place, and we say a lot the math ain't mathing, right? Like
No.
This isn't the only place in healthcare for sure, and in a lot of industries, I'm sure. But this is the one we live and breathe in.
Yeah.
So what's broken that's causing this? I mean, trust, engagement. I mean, we know the incentives are, but yeah, what's
Bad
broken
actors. There's bad actors out there. There's I've yet to meet a person in my client base in pharma and manufacturer distributors that I thought was evil. I haven't met them yet. Everybody that I meet is deeply in it for the patient. Yeah. I think our system's broken, right? And in my LinkedIn profile, I refer to myself as the Arthur Kirkland of healthcare, which is Al Pacino's character who breaks down in the courtroom and screams the whole system's out of order. The whole system's out of order. Right? It's not one, it's everybody. The incentives are misaligned. But when you talk to anybody, everybody cares about the two most important people in the equation. The doctor or the clinician and the patient. Everybody does. So where did it go wrong?
Where did it go wrong?
I know, it's a hairball. I wish I knew. I think that there's either you end up as a very wealthy person for solving it, or you end up assassinated, or you end up just doing the best thing you could have done for humanity. But I think it's completely broken.
Well, in the patient, that P in the pea soup, right, is the one who usually doesn't win, right? So if we think about like kind of our podcast, we talk about human connection, right? Connection with others, with our community, with ourselves. When we think about, let's just stick with, pharma and the patient, right? And how that communication happens between pharma and the patient to drive or erode trust. And can you talk about that communication and where the opportunities are there?
Yeah, sorry. How does the industry engage people? Let's talk about the patient first. I don't know if you watch primetime television, but about 1 in 3 ads in prime time are for a pharmaceutical product.
Yeah.
I think the manner in which we advertise, not that we advertise, is messed up. You can only do DTC advertising in the US and in New Zealand. You can't advertise drugs to patients in Europe. You can't do it in Asia, right? What's messed up is who sees ads on TV. I don't, because I have Netflix, I have Prime. So the people that see ads can't afford that. It's poor people see ads.
Right.
People who see ads are often technologically illiterate. They don't know there's a way to zoom past those ads, to skip them. And older people. So when you look at that, these are the people kind of that you want to reach if you want to sell them a medication, because they're most likely to be on insulin. They're most likely to have hypertension. They're most likely to be prone to cancers, certain cancers. And the amount of money that gets spent there, I think, can be rechanneled. Across the first 3 months of this year, according to iSpot TV, drug makers spent a combined $729.4 million to air commercials for the top 10 brands. That's up nearly $200 million from the year before. That's a big, big chunk of money.
Yeah. And it's so, I hear them because I guess where my brain immediately wants to go is even on advertising of tobacco, right, or something like cigarettes, right? But it's different because these things do help, right? But there's such a, I don't know, behavioral science tactics, psychological tactic of getting somebody to think that it's like just pushing it in front of them, rather than letting the doctor prescribe it, right? Like, yeah, we're forcing, or we're steering the patient back to the provider to say, hey, I saw this on TV. It looks like it'll help me. I really want it. Like, give it to me. Like, what do I need to do for you to prescribe it to me, right? And that's the wrong conversation typically, right? I mean, I'm all for educated consumers and educated patients. I wouldn't consider that necessarily an educated patient, right? Like that's...
No, the physician might not be able to. And oftentimes when a patient walks in and requests a drug, the doctor takes the path of least resistance and prescribes that drug. They might have needed to step up to it. Might have not been appropriate for them. It might not be covered by their insurance company.
Right.
So it's driving cost into the system. And I think we can do better. I think we can do better, and we can do well by doing better. Like, give me 10% of that. I'll take, give me 1% of that $729 million, and let me put an experience program into place and truly understand what people's expectations are, where they're not being met, and how we can better support them. Yeah, I was at a conference on Monday, and there was a speaker who they make their money off of this. They
Sure.
to an extent perpetuate the problem. They work with ad agencies. And they said that 67% of chronic patients who saw a DTC ad took an action and people clapped. Like, whatever are you clapping about? She didn't say what the action was. She didn't say what it costs to get that action. I mean, I'd kill, maybe not literally, maybe for a small percentage of that budget to put a program in place.
Right. And took an action, but yeah, was it the right action even for her, right? Even for the person
It's a bad
the
stat.
action.
Yeah.
Yeah, agree. I mean, that's feels like an example of how some of these P's sabotage each other, right? I mean, are there other core ways that you want to tell us about today?
Yeah, I mean, look, there's the other side of the equation too. Kind of, if I look at the formula, it's not just the patient. We have to message the doctor as well. So for every dollar we spend messaging the patient, we're probably spending $2 to reach the healthcare professional. It's media, that's conferences, that's events, that's samples of drugs, and samples are insanely important. Educating doctors is insanely important. But the model might be out of whack. Look, doctors don't hate sales representatives from industry. They actually largely value them for the information that they bring. But is there a better way to do this? I mean, and I also don't want to discount the other side of the house because pharma device are divided into commercial and medical. And there's very strict rules about what they can and cannot say and can and cannot do.
Sure.
They deliver great value to the industry. But I think we need to rethink the whole notion of a sales rep and maybe look, because the system's broken, because the system's out of whack, maybe look at, the rise of what I would call the resolution rep. Are we putting people in place to reduce practice burden? If we've got, look, everybody listening to this probably knows that physicians are burned out. Most physicians wouldn't recommend a career in medicine to their own kids. But, the Physician Foundation study looks every 2 years at what physicians believe is the most rewarding part of being a doctor. And it's collegial collaboration, scientific curiosity, prestige, money, and relationship with patients. Year over year over year, it's the relationship with patients, yet they work in a system that conspires against their aspiration.
To shorten that
gosh,
time, yeah.
That's so hard to think about. Don't contribute to it. That's all I'm asking. Don't contribute to that.
Yeah. And that was, one of the great points in Compassionomics was around, around if the doctor or nurse or physician's assistant or nurse practitioner or whoever, if that patient feels like that person knows them or is trying to know them as a human, as a person, and not just as, 5 minutes in and, hey, not looking at you, just looking at the computer, typing in the notes, right, in the EMR, but zero eye contact, zero physical contact. Again, the hand on the shoulder, hand on the elbow, like, hey, how are you? Like that goes so far, not just in building trust and helping them to open up, but helping them to adhere to whatever the doctor is going to advise them to do. And I mean, there's when you say it, the system conspires to not let that happen, right?
I refer to it all the time as, it simply needs more gas. And people are like, oh, we need to go faster? I said, no, it needs more gas. They said, oh, we need to set it on fire? I said, no, gas is an acronym for gives a shit. Just need to show up. Like you really give a shit about this person. You really care about this person. And I'm fortunate to have, like with my health, I must seek them out, or I must know how to find them. Or maybe it's a higher percentage. I have great doctors, incredible doctors. I have fired doctors. I have gotten in arguments inside of doctors' offices. I had a doctor walk in one time, and asked me what's going on, and I started to talk, and he interrupted me within seconds. Asked me another question, I started to answer, he interrupted me again. I said, you've now interrupted me twice. You've asked me what I'm feeling. You asked me what's going on. I'm trying to get it out, but you keep interrupting me. Can you stop doing that? And he looked at me like, shut up, I'm in charge here. I said, you know what?
Yeah. Who are you to talk to me?
I look like I look when I walk in the room. I'm probably wearing overalls and a flannel shirt and pulled up on a motorcycle. So he's kind of thinking, this guy doesn't know what he's doing. And I just said, look, this isn't going to work between us. It's not going to work. It's not me, it's you. And I think patients need to be empowered to understand that, who am I dealing with? Am I dealing with the right person? Are we a match? Are we simpatico? Are we going to have a relationship where I can trust you and you can trust me to do the right thing? And it is reciprocity. Reciprocity is such a, like, I have a metric that I use that I created with my clients in the customer experience that I call the helpfulness index. And I'm not measuring your drug. I'm not measuring, what I'm measuring is, are you showing up as a manufacturer, as a helpful partner, within compliance, within guidelines, but are you simply showing up helpful? And if you can ease practice
For the patient or for all stakeholders, is it focused on helpfulness to the patient?
Yeah, to the patient and to the provider. Are you simply
sure, yeah.
showing up cognizant of their needs and their time, what their expectations are, and adapting to meet those expectations? And a lot of it's derived from work. I stepped out of life sciences to work on a project around tourism with the Austrian Board of Tourism and some of my partners, where we looked at, where do people feel good along the journey and why don't they feel good? And what would happen if we adapted and we adjusted those moments where the friction were? Are they more likely to be loyal and come back? Turns out they are. Turns out they spend more money. Turns out they return to the same places year over year and they tell their friends. So we're adapting that same metric into healthcare.
Yeah, that's phenomenal.
Yeah. So cool. So much fun.
With the example even that you gave of your doctor, right? So it makes me think of it, and I feel like I'm like, like on a promotion tour for Compassionomics. I'm not. I just finished reading it and it's stuck in my head as we have this conversation. But
sitting right here.
You got it. Yeah. So one more thing on that book. It talked about basically like negative experiences and positive experiences that people have, in healthcare, and how negative experiences are much more impactful, obviously, than a very, very, very like knocked out of the park positive experience. Like what we need to do is make sure these negative experiences don't happen.
Yeah.
I feel like we spend much more time on, at least some organizations, on let's make sure these things that we have a lot of control over, we knock them out of the park, but we don't necessarily focus on these, and these impact everything more, the negative ones than the positive ones, I guess. And I think about like your doctor not listening to you. That's such a classic one, right? Where, it's a CAPS survey measure.
Yeah.
How, your doctor, how does your doctor communicate with you? How do you feel about that? And it's such an important driver in the experience, because that is your gatekeeper, right? That is your, that is the person that's, that's largely responsible for how you navigate through this journey, not step by step necessarily, but like the outcome between you and the doctor, the patient and the doctor, right?
And that problem got worse. I mean, it got worse because my experience was so bad, I didn't go to the doctor. I didn't go to somebody else.
Exactly, yeah.
Yeah, and Tresiak and Mazzarelli did another book called The Wonder Drug, which basically provided the scientific proof that compassion, right? And I look at compassion as empathy's more athletic cousin. We talk about empathy all the time, but compassion is actually doing something, and it talks about the benefit to the clinician in being compassionate, emotionally and performance-wise.
Say that again. Did you say empathy is compassion's more athletic cousin, or compassion?
I think compassion is empathy's more athletic cousin. Empathy is feeling for you and feeling what you feel. Compassion is actually doing something about it.
Gotcha. Okay.
Yeah.
More athletic cousin. I love that. Yeah. Have you written a book yet?
Yeah, I was going to talk about that. One of your questions that you share with me about I think it was a question about regret or something.
Yeah.
I have started a bunch of books. The one that I struggle with most that I haven't finished. It was your question about your most helpful personal failure.
Yeah.
I've started writing a children's book.
Ah,
Yeah,
awesome.
and
About pharma and the patient experience.
yeah, yeah. It's just to scare the living hell out of kids late at night, so they don't bother you. No, it's actually just it sprung up when my youngest. So I've been working this for a long time. He had a peanut allergy, and then he had a shellfish allergy and a bunch of allergies. And I started writing things to make him feel safe and telling him stories to make him feel safe. And my wife said to me one day, she goes, this isn't just for him. This is for more kids than that. So it became a bunch of stories about kids, how they feel in the world, how they interact with people.
It's not finished yet.
It's finished, and I've not been brave enough to put it in front of a publisher.
I love the way you said that, right? Because I was just about to tell. Look, actually, the book I started reading this morning is The Courage to Be Disliked, right? And one of the things that book talks about, it's actually really good, but it talks about like people who want to write a book and haven't finished it.
Oh, really?
I'm definitely one of those people who have started even a few, but I've never finished it. And the excuse usually is I didn't have time, or I don't have time. I'm just too busy. And they make the point that that's like. It's not really the reason is you are not doing it because number one, it's comfortable to say, I would do that if I had time, or I could do that if I had time.
I don't even blame time.
But it's usually you don't have the courage to do it because you don't want somebody giving you feedback on it, or the market giving you feedback on it, or somebody somebody trying to imply that they don't know what they're talking about, or it's not very good.
Yeah.
It's that reason. It's courage, right? It's courage. It's not time. So you just embodied that, right? By saying you haven't been brave enough to put it out there.
It's imposter syndrome. It's all of those things wrapped up in one. And that's like I talked about earlier, earlier in my career, being humbled by getting sick was a gift. It really was. It sucked, but it was definitely a gift, because if you haven't experienced it, if you haven't been in the system and seen it, then how are you going to help other people?
Yeah.
Right. So it was a pretty profound thing, but yeah, it's imposter syndrome more than anything, I think.
Well, my kids are all grown, but I have two grandkids.
Do you?
3 weeks old and 2 years old, and I promise I'll buy the book.
Okay.
And I'll read it to both of them as soon as you get it out there.
Okay. Yeah.
So go do it.
I actually spent like 5 months ago. I spent probably 2 solid months late in the evenings after I finished working on it. Ended up writing 4 new stories within the book. It's a series of kind of small stories.
Yeah.
Yeah.
Yeah, I can't wait to read it.
Okay. All right. I'll finish it.
In addition to that book, which clearly everyone needs to read, what's another book that? And these are kind of those rapid fire questions that we like to ask every guest. So what's another book that everyone should read?
Gosh, we talked about Compassionomics. We talked about The Rabbit Effect by Dr. Kelly Harding. There's a book called Awe by a gentleman named Dacher Keltner. And awe is kind of this shared human emotion. Like if you've experienced awe, you've experienced awe. But most of the times, awe comes from something that he describes in the book as moral beauty. And moral beauty is most often felt in the witness of a human doing something for another human. That
moral beauty.
Yeah, read that book. It's fantastic. It's called Awe: The New Science of Everyday Wonder.
Okay, I've actually studied a little. I've never read that book, but I have studied about awe because I find myself chasing it, right? And even in college, I remember I'd tell my roommates, guys, let's do something unforgettable, right? And that was just more about the experience. And when I think of awe, I think more about like a sunset or a sunrise or a mountain or some beautiful thing that you saw.
Yeah.
But I think seeing an incredible act of kindness or something can give you maybe that sense too. Right? But I want to read this book.
Yeah, because that's the whole crux of it. I also, anything by Yuval Harari, Sapiens Nexus.
I read Sapiens recently.
I love those books. They frighten me. And then Unreasonable Hospitality by Will Gardera.
Okay.
Yeah. I fell into being a filmmaker because I was an English major in college, and you realize like, oh, I'm not going to make any money if I teach high school English. So
Exactly.
as much as I love it, the best thing about that major in college was it taught me how to consume a lot of information. So I'm surrounded by books just all the time. Yeah.
I'm an avid reader. I have a ton of books. I grew up though wanting to be a coach, and I love sports and played sports and love coaching, volunteering coaching. But I didn't think I could make any money, so I didn't become a coach.
Yeah.
So I started a business.
Same.
And,
I spent 18 years volunteer coaching, and I loved it.
Yeah. What's a belief you swear by?
Dogs and horses. There's nothing better. I have both. They're selfless, and the cool thing that you learn about them primarily with horses sync to something that's called your variable heart rate, and that's the space in between your heartbeats. So when you're calm, they will be calm. If you're ramped up, they will get ramped up, and it can go both ways. But they signal to you a lot of things. So when I go in the barn in the evening with my horse, if I walk in there stressed out from my work day or with my earphones in on a work call, he lets me know really, really quickly to cut it out and chill, and he resets me. And same with my dogs. We have two rescues. We have a never ending stream of rescues that we rotate in when one of them tragically or magically leaves, and they're just the best thing in the world.
Yeah, we have a couple of dogs, and the highlights of our lives. Pretty much.
So that's my belief.
It's so funny because I've asked this question to a lot of people, and everyone else, it's like a phrase, or it's like which I'm not dismissing that. That's normally what I would expect, right? Is be kind. What's a belief you swear by? Like, never give up. Like, and usually dogs. Like, I love that because I totally agree too. Like, dogs are so important and so grounding for me, and one of them sleeps with us.
Yeah,
and,
there's nothing better. I saw a quote by Ricky Gervais where he said, "Dogs are my heroin."
I've heard Ricky say, I like Ricky. He's one of those kind of over the top polarizing guys, but I've seen what's it called, End of Life or something on Netflix this series, and seen a lot of his interviews and his thoughts on even religion, and he is so thought provoking. And
Life After the series he did.
That's it.
Yeah. Was absolutely brilliant. It's the only series I've ever seen where you could be crying 1 second and laughing out loud the next.
It's so unbelievably dark in moments, but you feel good after watching it because of the way it's. Yeah, I totally agree.
Yeah.
Hardest decision you've ever had to make?
I think letting go of people, like people you're supposed to care about and supposed to love, but there's an energy thing between the two of you, and letting go of that. That's hard to do.
Yeah,
that's really hard to do. But sometimes, just because something's tenacious doesn't mean that it's worthy, and so that's hard. That's hard to do, and it's hard to realize. It's hard to teach.
Yeah. A lot of relationships, whether they're personal or through work or even employment based, right?
Yeah.
Like a lot of relationships. I don't know. I don't like the way this sounds, but I believe it. Like have a shelf life, right? And like like there's a time when something else might need to happen.
Yeah, and it happened for a reason.
Exactly. Yeah.
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 I believe.
And our lives are kind of written in chapters, right?
Yeah.
And every chapter is different.
Yeah. For sure.
Any events or successes or failures that made you lead like you do today?
You know what I thought about when I read that? Because I went to a conference the other day, and it was a pharmaceutical conference, and there were some people I hadn't seen in years that I used to work with. And I noticed after the first day they hadn't picked up their badges, and on the second day they hadn't picked up their badges, and I messaged and reached out, and they had gotten laid off. And there's a lot of that in this industry right now, and that's why I love the industry. It's an extremely hard industry. It's very volatile, and people don't always recognize that. But one company just let go 9,000, one let go 2,000, and I kind of live in the pharma corridor, so it made me think about that in the context of this question about successes or failures, because I've lost jobs, and what I thought about it, I looked at those things as a failure, but now that I look back at them, they were a gift every single time.
Yeah.
Right? It pushed me into a different place. It rewired me, and it's sad, and it's tragic, and it's hard, and it's scary, but I'd take it again.
Okay, Rich, last question, and I'll let you go.
All right.
How would you finish this sentence? For me, one of the most important ways to human up is to blank.
Yeah, this one I was struggling with a little bit. Like, be insanely generous with people. Shut up, listen. But then I thought about, when my oldest son was going off to high school, and he's 31 now. He was very shy, and he was very scared, and he'd had some challenges, and he'd been bullied and stuff. And I'm driving him to high school. And I had a high pressure job at the time, and I'm driving to school because he didn't want to take the bus. And he looked at me, he said, "Dad, do you have any advice for me, like what I should do to kind of fit in school?" And I didn't want to deal with that question right then and there. I was like, I was distracted, which I shouldn't have been. And unknowingly, I said something very prophetic to him. I said, "Don't be a jerk." I didn't say jerk. I said a different word, but I said, "Don't be a jerk." Yeah. And I dropped him off at school. And my phone rang a short while later, and it was my wife. And she said, "That's your advice. That's your fatherly advice." Well, 4 years later, he graduates from school, and he's elected the most popular kid in the school and one of the most influential kids in the school, and he's celebrated at graduation just for being a great guy. And he said, and his freshman asked me, like, "How do you do that? Like, you hang out with the jocks and the heads and the motorheads and the weirdos, you hang out with everybody." And he goes, "Very wise man once told me, don't be a jerk." So if you're being a jerk, if when you're doing it, right? When you're doing it. Yeah. And there's a reason you're doing it, for your own safety, your own security. Like, give that other person grace.
It's perfect. No, I think, yeah.
That was a long answer, so just give people grace. Give people grace.
Don't be a jerk. Yeah. I think we can boil up the HumanUp Imperative. I think we can say that's the catchphrase. Yeah. I think that works. Rich, how can people keep up with you or follow you if they're interested?
You'll find me in a barn. No, I'm on LinkedIn. I'm easy to find there. I look like me, so look me up there. I write a newsletter I call RX for CX, where I talk about things bigger and broader than customer experience, and just how the industry is shaping and reshaping. So that's probably the best way to find me.
Yeah, it's a good one. I follow you and subscribe to that, and I always read that. You're a great writer, and you're seriously, like the way I teed you up, like thoughtful and thought provoking. Like you want to do something when you read these things. So that's a gift, man. So I hope you write that book. And other books for kids, definitely, but books for us too.
Yeah, thank you. That was enough. That's the second Second time in 2 days, somebody nudged me.
Well, there you go. It's how many signs do you need?
Two's enough.
Two's enough. All right. Rich, thanks so much. I really appreciate it.
Thank you, guys.
All right. We'll talk next time. Thanks, everyone.
All right. Take care.